Hello, my name is Aloha Ketbagan, and my report is on systemic lupus erythematosus. Systemic lupus erythematosus is a chronic autoimmune disorder that causes widespread inflammation and tissue damage across multiple organ systems. It presents with diverse clinical manifestations and fluctuating periods of remission and exacerbation, making management challenging. Because of its heterogeneity and relapsing course, it remains one of the most challenging diseases to diagnose and treat. This presentation explores the historical background, pathophysiology, diagnosis, and treatment of lupus with an emphasis on evidence-based strategies used in nursing practice. Systemic lupus erythematosus was chosen as the focus of this presentation due to its complexity, unpredictable course, and the significant challenges it presents in patient care. First, let's define systemic lupus erythematosus. It is a chronic autoimmune condition characterized by multi-system inflammation and immune dysregulation. The body's immune system mistakenly attacks healthy tissues, leading to damage in organs such as the skin, kidneys, joints, and the heart. Cited from the National Institute of Health 2024. This presentation will examine evidence-based pharmacologic and nursing strategies for SLE management. Both pharmacologic and non-pharmacologic interventions are reviewed, including corticosteroids, anti-malarial agents, immunosuppressive drugs, biologic therapies, and patient-centered education. Current research trends such as targeted biologics and digital monitoring technologies are discussed as part of a modern interdisciplinary approach. We'll also touch on the recent advances such as precision medicine, stem cell transplantation, and telehealth applications. This presentation will also demonstrate the integration of AACN essentials using advanced pharmacologic knowledge to support safe, evidence-based care. Because no cure exists, treatment goals focus on controlling disease activity, preventing irreversible organ damage, and improving quality of life. Cited from Call et al. 2024. The history of lupus extends back to the Middle Ages when physicians first described characteristic skin lesions resembling wolf bites, hence the term lupus. In the 19th century, dermatologist Ferdinand von Hebe and his student Maurice Kaposi described lupus as both a cutaneous and systemic illness, cited from Merrill Wallace 2022. In 1895, Sir William Osler further recognized the systemic nature of the disease, noting involvement of internal organs, calling it erythematosus. Scientific breakthrough in the mid-20th century marked a turning point in lupus care. The discovery of LE cell and anti-nuclear antibodies, ANA, provided critical diagnostic markers confirming lupus as an autoimmune disorder. Introduction of corticosteroids in the 1950s dramatically improved survival, transforming the once fatal disease into a manageable chronic condition. The later development of immunosuppressive agents such as azathioprine and cyclophosphamide further advanced therapy, allowing physicians to preserve organ function. Today, biologic medication and genomic medicine continue to expand the therapeutic landscape. Biologic drugs target specific immune pathways, are redefining lupus management, emphasizing precision medicine, and improved patient outcomes. Cited from Merrill Wallace 2022. Lupus affects approximately 1.5 million Americans and an estimated 5 million people globally, with women of childbearing age comprising nearly 90% of all cases. Cited from Pons Estelle and Alarcon 2023, with a female-to-male ratio of nearly 9 to 1, cited from Fornoreakis et al. 2023. Incidence peaks between the age of 15 and 45. Lupus disproportionately affects women of African American, Hispanic, Asian, and Native American background, causing not only higher incidences but also greater organ damage and poorer outcome. Cited from Fornoreakis et al. 2023. Pathophysiologically, systemic lupus erythematosus arises from a breakdown in immune tolerance. It involves dysregulation of the immune system, leading to autoantibody production and immune complex formation. Normally, apoptotic cells are cleared without inflammation. These complexes deposit in tissues, triggering inflammation and organ damage. Impaired clearance exposes nuclear antigen that activates B cells and T cells. B cells play a central role by producing autoantibodies, such as anti double stranded DNA and anti Smith antibodies, while T cell dysfunction perpetuates inflammation and tissue injury, cited from Suko et al. 2022. Over time, persistent inflammation leads to fibrosis and irreversible organ damage. Organs commonly affected include the kidneys, causing lupus nephritis, a major cause of morbidity and mortality, skin and joints, frequently shown with photosensitive rashes, arthritis, and alopecia. In the cardiovascular system, accelerated atherosclerosis raises the risk of myocardial infarction. The central nervous system causes patients to develop seizures, psychosis, or cognitive dysfunction. The severity and progression vary widely, underscoring the need for individualized management, cited from Sugo et al. 2022. Cytokines such as interferon A, interleukin 6, and tumor necrosis factor A amplify the response. B cells activating factor BAF levels are often elevated, promoting autoantibody production. The American College of Rheumatology (ACR) and the European Alliance of Association for Rheumatology (EULAR) updated classification criteria in 2019. These criteria require at least one clinical and one immunologic criterion for diagnosis. ANA must be greater than or equal to 1.80 and additive weighted clinical and immunologic domains totaling greater than or equal to 10 points, with ANA positivity as an entry point, cited from Ehringer et al. 2023. Serologic marker will show positive ANA. ANA is positive in greater than 90% of cases. It will also show positive anti-double-stranded DNA, anti-Smith antibodies, anti-ribonucleic protein antibodies, and anti-phospholipid antibodies, cited from Ehringer et al. 2023. Complement levels below C3 and C4 indicate active disease. National Institute of Health 2024. Urine analysis showing proteinuria or hematuria may suggest lupus nephritis, cited from the National Institute of Health 2024. Therapy is individualized based on disease activity and organ involvement. Medication therapy aims to control inflammation, prevent flares, and minimize organ damage. Corticosteroids such as prednisone and methylprednisolone remains cornerstone therapy for acute lupus flares. They rapidly suppress inflammatory effects by inhibiting multiple cytokines but carrying significant side effects including weight gain, hypertension, osteoporosis, and glucose intolerance. High doses treat acute flares, while low dose regimens maintain remission. Nurses monitor these adverse effects and educate patients on gradual tapering to prevent adrenal insufficiency, cited from ACR 2023. Antimalarials such as hydrochloroquine is the foundation recommended for all patients with lupus unless contraindicated. It reduces mortality and prevents thrombotic events. It also lowers disease activities, prevents flares, and offers cardiovascular benefits, cited from Yap and Chan 2022. It stabilizes lysosomal membranes, interferes with antigen presentation, and reduces autoantibody production. Regular ophthalmologic exams are essential to monitor for renal toxicity. Immunosuppressive agents such as azathioprine, methotrexate, and mycophenolate mofetil are used to reduce steroid dependency and manage moderate to severe disease by interfering with DNA synthesis. Cyclophosphamide remains effective for severe nephritis or CNS involvement. Nurses must closely monitor blood counts, liver enzymes to detect toxicity early, cited from the National Institute of Health 2024. Nurses must also reinforce infection prevention strategies and contraception counseling. Biologic therapies or biologic agents target specific pathways involved in lupus pathogenesis. Belimumab targets B cells activating factors BAFF, reducing B cell survival, inhibit B lymphocyte stimulator, reducing abnormal B cell activity, while anifrolumab blocks type 1 interferon receptors, cited from Call et al. 2024. Both drugs involve flare control and steroid tapering success, representing major progress for patients unresponsive to conventional therapy. Clinical trials show belimumab reduces severe flare-ups by greater than 30% compared to placebo. NSAID and adjunctive therapies, like nonsteroidal anti-inflammatory drugs, are effective for mild musculoskeletal symptoms, mild arthritis, or psoriasis. Nonsteroidal anti-inflammatory drugs relieve pain and inflammation, but must be used cautiously due to renal and cardiovascular risk. Vitamin D supplementation, antihypertensive, and statins are frequently used to manage comorbid conditions, cited from Ernger et al. 2023. Vaccination, such as influenza and pneumococcal, is encouraged unless contraindicated by immunosuppression. Education empowers patients to control their disease. Key teaching points include avoiding ultraviolet exposure, using sunscreen with SPF greater than 30, practicing stress reduction, and adhering to prescribed medication schedule. Lifestyle change is necessary for adults with systemic lupus erythematosus to manage symptoms and reduce the risk of flare-ups, as well as reduce complications. Key changes include maintaining hydration, balanced nutrition, and getting adequate rest. Diets rich in omega-3 fatty acids and antioxidants help modulate inflammation, cited from Zoma in 2023. Lupus management demands lifelong follow-up. Nurses serve as educators, care coordinators, and advocates. Key long-term responsibilities include medication adherence by simplifying regimen, setting reminders, and verifying understanding of side effects, monitoring regular assessment of blood pressure, renal function, and body weight, preventive care, screening for osteoporosis, cardiovascular disease, and malignancy associated with chronic immunosuppression, emergency recognition, educating patients to identify infection signs and when to seek emergency services, interprofessional collaboration, coordinating with pharmacists, social worker, dietitians, and rheumatologists to ensure comprehensive management, cited from Fornoriakis et al. 2023. Lupus research is rapidly evolving towards precision medicine. Genome-wide association studies have identified over 100 susceptibility loci influencing immune regulation, cited from Suko et al. 2022. Researchers are testing B-cell depletion agent obinutuzumab for refractory disease, JAK inhibitors, baricitinib, and deucravacitinib that interrupt interferon signaling. Stem cell transplantation shows early success in reducing proteinuria and steroid dependency. Digital health innovations such as wearable devices, mobile apps, and telerheumatology platforms enable continuous system tracking and remote nursing assessment, cited from the National Institute of Health 2024. AACN essentials can be integrated through the use of current research to advance safe, evidence-based practice. Artificial intelligence models are being developed to predict flare-ups or biomarker patterns. Systemic lupus erythematosus is a complex autoimmune disorder that requires individualized, lifelong management and multidisciplinary collaboration. Nurses bridge clinical care and education, empowering patients to manage flares. Nurses help patients navigate lifelong illness with dignity and resilience. Nurses are uniquely positioned to build trust, address stigma, empower patients toward self-efficacy, which are the central goals in chronic disease nursing. Cited from Call et al. 2024. Advances in immunology, genetics, and biotechnology have greatly improved survival and quality of life. However, treatment success depends heavily on patient engagement and nursing support. By integrating pharmacologic therapies such as corticosteroids, immunosuppressant, and biologics, as well as lifestyle counseling and psychosocial care, continued research into biologic therapies and health technology innovation promise even more precise and accessible care for future generations. Nurses are central to promoting adherence, detecting complications early, and advocating for equitable care. This concludes my presentation. Thank you.